we're going to start ground rounds. Today, the presentation is by medical oncology with a lot of help from endocrinology. And the topic is going to be advanced thyroid cancer, radioactive iodine therapy and beyond. And we're going to have a case presentation by Jessie and Nguyen, and Nicole Gorddard is going to make some comments, and I'm sure Timothy Ferrantoline is going to make some comments at the end as well. There you go.
So yeah, I'll start with the case presentation first. And I think the case presentation can give an outline on how we normally manage thyroid cancer. So this is Mr. T. He's a 67-year-old male who's very well with good performance status of ECOG 0 at baseline. He's an active person. He's enthusiastic in sport and is very active in skiing. His past history is fairly limited. With only dyslipidemia, he's on rosuvastatin and ezetimibe. And the other interesting thing for him is that he's had a solitary benign thyroid nodule in his 30s, and he's had a right hemithyroidectomy back then. He actually presented to his GP with left hip pain. And during a UTI episode as well, his GP has done some PSA for him, showing it's slightly elevated at 5.7, and leading to some imaging. It started first with an X-ray, and that just shows some irregularity in the left eyelid. Therefore, it was suggested to go ahead with a CT scan. So he proceeded to have a CT chest, abdomen, and pelvis. And that has actually showed quite a lot of metastatic lesions. There are a couple of lung nodules, biggest about 8 millimeters. He's got quite a few bony metastases in the vertebrae, as well as in the ribs. And most significantly is this large destructive lesion in the left iliac wing, which we can observe here. At that stage, he went ahead and have a core biopsy of this left iliac wing lesion, and that has shown a metastatic follicular thyroid cancer. He then had an ultrasound neck to confirm that he does have a left thyroid nodule, and that's in the residual thyroid after the hemithyroidectomy previously. He also had a PET scan with FDG avidity noted in all of the lesions stated above, but the thyroid lesion was actually not avid. Concurrently, he's underwent some pathological testing. His thyroid function was actually all in the normal range, but his serum thyroglobulin, which we use in thyroid cancer monitoring, probably not as much useful for diagnosis, but regardless, it was extremely high at 15,000, with the upper limit of usually just only 30. So we've established that this man has metastatic follicular thyroid cancer. In terms of management, despite being a metastatic disease, we do go ahead and he did have a completion thyroidectomy, and that demonstrated an 8 millimeters minimally invasive follicular thyroid carcinoma with capsular invasion, and that was completely resected. He then went ahead and had local therapy to his sites of concern. So he had surgical debulking of the left iliac bone metastasis, followed by radiation therapy to the pelvis, as well as radiation to the concerning L4 lesion. At this stage, most of his management was, again, under endocrinology team. He's had appropriate TSH suppression back then, and he did have hormonal replacement to maintain this. After the surgery, patients would normally get their risk assessment scored, and given this man is a metastatic disease, making him a high risk case, he went ahead and have radioactive iodine treatment. Over the years, he had a total of 3 treatments, 200 millicuries each. He also received zoledronic acid infusion for his bony metastases. In terms of radioactive iodine treatment, so what it does is the patient get some oral radioactive isotope of the iodine 131. Then they come back a week later with the post treatment scan, which is what we can see here. This is after his first treatment in September 2017. So the iodine isotope would hopefully be absorbed by the thyroid cells and any thyroid cancer cells and get destroyed. What we see here is that we can see the uptake in the cancer, thyroid cancer lesions that we mentioned before. And it does give us some indication that this patient would benefit from this radioactive iodine treatment, given it is being uptaken into these thyroid cancer cells. Subsequently, he did have a repeat, another radioactive iodine treatment, and a third one in 2019. Over these treatments, we could see
Keep going.
that slowly we could observe less uptake in these lesions. Not necessarily meaning that there is no cancer cells there, but probably that he's developing radioactive iodine resistant and the cells are not uptaking the isotope anymore. This actually correlated with his serum thyroglobulin. The three arrows here indicate the three timelines where he received the radioactive iodine treatment. So with the first one, the first arrow indicates the post-op thyroglobulin, and that dropped significantly from the time of diagnosis, at which he received the treatment with reduction in the thyroglobulin level. However, by the time he get to the third treatment, we have not noticed such drop in the thyroglobulin anymore. This also correlates with a period where he would develop pain and with radiological progression noted in his right 7th rib, which we could see here, as well as T9. For this, he received radiation therapy to these treatments. And by this time, we defined that he's got radioactive iodine resistant disease, and he was referred to medical oncology for consideration of systemic treatment. Oftentimes, we normally start with genetic mutation testing to find a targetable treatment for him. So for this man, he did have a pathogenic variant detected, which was an NRAS. However, there was no targeted therapy available for this particular mutation. In that context, and with ongoing rise in the thyroglobulin, his option would be a tyrosine kinase inhibitor. In the first line, it is called Levatineb. After a lot of consideration, he was commenced on Levatineb, given Levatineb is a fairly toxic drug with lots of side effects. So lots of discussion was made throughout the consultations, and he was commenced on this drug in May. He had a dramatic drop of the thyroglobulin from 2,000 to 282. He did have quite a few side effects from this drug, including severe fatigue, reduced exercise tolerance, diarrhea, and hypertension, requiring 3 agents. Therefore, throughout the course, to maintain quality of life, we had to reduce his dose. With a starting dose of 24, slowly it went down to 10 milligrams daily. This drug kept his disease fairly well under control for approximately 18 months until he developed symptomatic pain in the sternum and received some radiation therapy to the manubrium. So In the context of ongoing progression of disease and rising thyroglobulin level, now going back up to 1300, there was consideration for him to needing a second-line treatment, and at that time, cabozantinib has come available as an access program. Again, cabozantinib is a TKI inhibitor, and it also has quite a lot of side effects. This man was commenced on cabozantinib at the starting dose of 60 milligrams. And over the course, again, he had fatigue, diarrhea, mucositis, again, hypertension, and issues with delayed wound healing, particularly when he was having skin cancer treatment. Therefore, he required modification of the dose and various interruptions. And that brought him to the present thyroglobulin of around 2,000. And as we can see over the trend of over this last 6.5 years, from his diagnosis of metastatic thyroid cancer, he's on second line of treatment, systemic treatment, and we'll just have to see what he would be like in the future.
Okay, thank you. I'll ask if there are any questions related to this particular case. If anybody has any out there in webland, please write them in chat.
Question?
Yes, I think thanks for the case. Interesting. So I guess for a non-oncologist, are we just following thyroglobulin as a way of noting whether this patient's got refractory or recurrent disease, or is there, are you watching something else?
The question is, are we just following the thyroglobulin, or are there any other markers of progression?
So we use both thyroglobulin and interval scans.
The scan results, you were saying it may be resistance or reduced uptake of the iodine because of the evolution of the cancer, so it may not have been a particularly sensitive test.
We we only do that uptake scan whenever the radioactive iodine treatment is given to see the result from the treatment, whereas for our surveillance scan, it's normally CT scans.
Okay, we'll move on to the presentation by Nicole Gorddard.
Thank you. I'll just start off with some Australian statistics about thyroid cancer. And so the data from the Australian Institute of Health and Welfare data shows that only 2.5% of all the new cancer cases in Australia are actually thyroid cancer. But in fact, an even smaller proportion of cancer-related deaths are due to thyroid cancer in Australia, about 3 in every 1,000 cancer-related deaths. And as you can see, thyroid cancer is generally a pretty indolent disease with patients surviving for some years with their disease. And 97% of all the thyroid cancer patients in Australia will still be alive 5 years after their diagnosis. We divide it up into the thyroid malignancies or cancers which are derived from the follicular epithelium, and they're the most common. In particular, differentiated thyroid cancers, so the iodine-sensitive disease. You can see that papillary thyroid cancer is the most common form of thyroid cancer, accounting for about 85%. Follicular thyroid cancer is less common, a little bit more aggressive, and tends to affect a slightly older population. And Herschel cell carcinoma is also a little bit more aggressive. Anaplastic thyroid cancer is actually also derived from follicular epithelium, but is a very undifferentiated malignancy. It's fortunate that it only accounts for 1 to 2% of all thyroid cancers because it's extremely aggressive with a very poor survival. And then we have medullary thyroid cancer, which is a completely different disease entity. It's actually a neuroendocrine tumour, which is derived from the parafollicular or the C cells of the thyroid gland. It only accounts for 2 to 3% of all thyroid cancers. And they usually release calcitonin. So in medullary thyroid cancer, we can use calcitonin as a tumour marker, whereas as you've seen in the differentiated thyroid cancers, they generally will release thyroglobulin, and that can be helpful in most of those as a tumour marker. So I thought I'd just make it clear that today we're actually really very much focusing on differentiated thyroid cancers. And so the discussion that follows is not relating at all to anaplastic thyroid cancer, medullary thyroid cancer, nor thyroid lymphomas. So in terms of thyroid cancer, in fact, most patients don't die of their thyroid cancer, especially if they don't have metastatic disease at diagnosis. It's only about 15% of these differentiated thyroid cancers that do develop distant metastases. But actually older patients tend to have a bit more aggressive disease and worse survival. And also patients that have advanced disease at diagnosis, unsurprisingly, tend to have worse survival. Papillary thyroid cancer has the best prognosis, and as we saw, that's clearly the most common of the thyroid cancers. And just to mention, Hürthle cell carcinoma used to be thought of as a subtype of follicular thyroid cancer and as a slightly more aggressive disease, but in fact it is a separate disease entity and it's quite molecularly distinct from the other follicular thyroid cancers. Even when patients have distant metastases, as we've seen, they can survive for years, particularly if there's just low volume lung metastases and also if they've got radioactive iodine sensitive metastases. I borrowed this slide and some of my other slides from a presentation at the American Society of Clinical Oncology, and I thought it was important to put this up because I think thyroid cancer demonstrates beautifully the importance of a multidisciplinary team, and you really will see all these people involved in thyroid cancer treatment. And in fact, medical oncology and radiation oncology have a pretty small role to play in treatment of thyroid cancer because most of the patients are actually cured by the surgeons, endocrinologists, and nuclear medicine physicians. So obviously the initial management is surgery, and then for most of the patients, particularly those who have intermediate or high risk disease, they're then managed with TSH suppression and, as you've seen, radioactive iodine treatment. And really the rationale behind that is that your normal thyroid follicular cells, they take up radioactive iodine via the cell membrane sodium iodide symporter or transporter. And in fact, the differentiated thyroid cancers also have that the sodium iodide symporter and are also able to take up radioactive iodine, which can then cause cytotoxic DNA damage and cancer cell death. The cancers have reduced expression of the sodium iodide, but it's still present and obviously explains the benefits of this treatment. The aims of radioactive iodine are firstly ablation of remnant thyroid tissue, so treating the remaining normal or abnormal thyroid tissue, which is therapeutic, and then also can be helpful in future disease monitoring also. It's also used in the adjuvant treatment of subclinical micrometastatic disease. So when you've got high risk, nasty, aggressive disease where there's quite likely to be micrometastases, it's used post-operatively. And then obviously when there's clinically evident or obvious distant metastases that take up radioactive iodine, that's also used in this setting. So in terms of metastatic differentiated thyroid cancer, radioactive iodine has actually been in use since the 1940s, and there's no randomized controlled trial of the use of radioactive iodine versus no radioactive iodine in these patients, unsurprisingly, when it's such a long treatment, and clearly that would be unethical now. But we do have some good evidence of the benefits of this treatment, and I think one of the papers which is particularly helpful on this front and very interesting long-term data is that published by Duranty and others in 2006. This was a very impressive cohort study of more than 400 patients at a French institution who had been treated between the 1950s to the mid-1990s. And patients who all had distant metastases from papillary and follicular thyroid cancer who'd been treated with radioactive iodine, so I-131. And what they saw in their follow-up was that if patients did achieve normalization of their scan, so a negative scan post the I-131, 92% of them were still alive 10 years later. Whereas if the patients didn't achieve a negative or a clear scan post the radioactive iodine treatment, then only 19% of them were still alive 10 years after the treatment. In this study, this is a survival curve also. So in this particular survival curve, they've plotted on the top line, you can see the patients whose metastases took up some radioactive iodine full stop. So this is at the time of initial treatment was there any radioactive iodine uptake in those metastases? And if there was any, didn't tell you what kind of response you have, but you can see here that obviously much improved survival curve compared to the bottom survival, where these are patients whose metastases at the time of diagnosis, even with that initial treatment, didn't take up any radioactive iodine, clearly had worse survival. So I think, this data is really telling us that differentiated thyroid cancer metastases, which never take up radioactive iodine, unsurprisingly have more aggressive disease and a worse prognosis. And we can sort of think of this as primary radioactive iodine resistance. But also patients whose, cancers do take up some radioactive iodine but had an incomplete response also have a worse prognosis. So definitions of radioactive iodine resistance can vary, but the following are very well accepted, I think. So firstly, as we've seen in the previous slide, so recurrent or metastatic disease which just doesn't take up radioactive iodine, so that when there's a diagnostic radioiodine scan or a post-therapy radioiodine scan, there's no uptake of the radioactive iodine. Then also thyroid cancer metastases which have started to grow again within 6 months of radioactive iodine treatment are considered resistant. And a mixed disease response is also considered RAI resistant. And so what that means is when you've got multiple metastases, some of them may take up the radioactive iodine, but others won't take any up at all. And then I think the last point is a little bit more contentious, but still generally agreed that thyroid cancer metastases which are progressing despite a previous cumulative dose of radioactive iodine of 600 millicuries is also considered resistant. And that would involve several doses of radioactive iodine. In terms of treatment of RAI-resistant thyroid cancer, when there's just very low volume or limited disease, oligometastatic disease, we do consider local treatments for that. So surgical resection of very limited metastases, if that would be feasible, or if they're very troublesome metastases. And external beam radiation can be very helpful also in treating limited metastatic disease, particularly if you have painful and symptomatic sites. But certainly if those things aren't feasible or you have widespread disease, that's when we need to consider systemic therapy. Currently, that's essentially molecularly targeted drugs with tyrosine kinase inhibitors. Cytotoxic chemotherapy was used decades ago. It has some disease activity, but it doesn't provide durable responses and is pretty toxic. So we generally don't use chemo in thyroid cancer these days, at least differentiated cancer. So I thought it would be helpful to have a think about the biology and what's going on in these differentiated thyroid cancers. And you can see the various mutations which are seen with some reasonable frequency. The BRAF V600E mutation is present in at least half of the papillary thyroid cancers. And this is the same BRAF mutation that's very well known and characterized in melanomas. But there are other, you can see here, NRAS and HRAS mutations are seen, NTRK, RET fusions, TERT promoter mutations. So there's quite a lot of mutations that can occur. And I think it's important to think about what's happening in the cell cycle here. So in fact, obviously, the RAS is a small GTPase, which is apparently the most frequently mutated oncogene in humans. And that feeds down to these two very important downstream signaling pathways, which have an effect on cellular proliferation, differentiation, and survival. So here we have the MAP kinase or the MEK pathway, so mitogen activated protein kinase pathway, which is very important in thyroid cancer growth, and also the PI3 kinase downstream signaling pathway. So you can see that these, these mutations are largely affecting these two important downstream signaling pathways. But in fact, compared to other malignancies, thyroid cancer, sorry, I'm not moving this very well, generally has a low tumor mutation burden. And I thought this was nice to sort of explain some of the drugs. So again, we've got the cell, we've got our membrane growth factor receptors here, which all can have, feed down onto the RAS and then down these important downstream signaling pathways, PI3 kinase and the MAP kinase pathways. So up the top here are some of these multi-targeted kinase inhibitors. And I guess you can now appreciate why they're called multi-targeted kinase inhibitors, because they hit multiple of the growth factor receptors. So if we look at Levatineb, for example, the drug our patient first have, Levatineb can inhibit vascular endothelial growth factor, platelet-derived growth factor, FGFR, and RET. So, you know, and similarly for the cabozantinib, again, there's some crossover. It can inhibit VEGF receptor as well as c-MET and RET. So these are the multi-targeted tyrosine kinase inhibitors. And then down the side, we have sort of more, I guess, specific mutation directed agents. So for example, if you had a tumor with a BRAF mutation, you may look at dabrafenib, which is a specific BRAF inhibitor, and so on. So one of the first trials that showed the use of the multi-targeted kinase inhibitors in radioactive iodine resistant metastatic thyroid cancer was Seraphinib. And we can see here it was a randomized controlled trial showing an improved progression-free survival of about 5 months compared to placebo. I think more exciting data was the subsequent Levatineb trial. This was known as the SELECT study, a phase 3 randomized double-blind trial of 24 milligrams of Levatineb daily versus placebo in, again, radioactive iodine resistant metastatic thyroid cancer. And I just want to point out that in this trial, at the time of disease progression, patients in the placebo arm were offered Levatineb, which is lovely for patients, but I think but also this means it's very hard to demonstrate an overall survival benefit. When you're crossing over in an indolent disease, in some ways, this trial is a little bit more testing. Is there a survival benefit to Levatineb starting early versus waiting till the cancer grows a bit more? So the primary endpoint of the survival was progression-free survival, and quite an impressive improvement in progression-free survival at 18 months in the Levatineb group versus 3 to 4 months in the placebo group, and that was obviously statistically significant. So we can see here the improved progression-free survival with Levatineb compared to placebo in this trial. It was a first and second line trial, so 3/4 of the patients had never had any tyrosine kinase inhibitor for their metastatic disease, and just 1/4 of them had had a previous drug such as Seraphinib. Giannakakis and others then updated some of the progression-free survival in the responding patients from this study in their endocrinology-related cancer journal in 2018. And they looked at the patients in the trial who did actually have a radiologic response and were able to demonstrate that in that group of responders, their median survival was actually 33 months. And I think nice data just to show for those patients that are getting radiologic response, it's really quite durable, with half of them having sort of nearly 3 years of disease control or cancer under control on imaging. I alluded to the fact that it's hard to find an overall survival benefit when we've got significant study crossover. And that SELECT study as a whole did not show any significant overall survival benefit with the use of Levatineb. But in fact, in the older group of patients, they did. And so this is the curve on the left here, where in blue is the patients that had Levatineb, and in yellow is the patients who had placebo, but then were offered Levatineb on progression. That is interesting because we know that the older patients tend to have the more aggressive disease and worse survival in general. The younger patients who tend to do better anyway, there was no obvious overall survival benefit noted. As Jessie's already told you, these drugs, they are very convenient in that they're oral tablets, but they are chronic medications and unfortunately do carry a lot of toxicities. And so in particular hypertension. So this is grade 3 and 4 toxicities, so moderately severe and severe toxicities. Hypertension is incredibly common. I don't actually remember having a patient on Levatineb who I didn't have to increase or start blood pressure medication on. But they can cause quite a bit of GI upset, including diarrhea, skin rashes, including the hand-foot skin syndrome, a lot of asthenia, fatigue, decreased appetite, and also have to be monitored for proteinuria. So the story you heard where the treatment is started and stopped and there's lots of dose reduction is pretty much par for the course with these drugs to try to maintain quality of life as well as controlling the cancer. clearly we have some work to do on that front. The data underpinning second-line therapy comes from this COSMIC 311 trial. This was published by Brose and others in Lancet Oncology in 2021. Again, radioactive iodine resistant metastatic thyroid cancer. This was a second or third line study. So all the patients had Levatineb or Seraphinib previously, and some of them had had 2 lines of TKI. So these are patients who are further down the line who've already been through some treatment. And again, randomized to cabozantinib or placebo. And we again saw a significant improvement in progression-free survival, 11 months in the cabozantinib arm and just sort of 2 months in the placebo arm. So the patients in the placebo arm, by the time you did the first scan, half of them were progressing. It was significant. It was the same study design where there was again crossover offered in the placebo arm on progression, and again no overall survival benefits to date, which is unsurprising. So what about future directions? I guess we wonder about the early use of more specific mutation-directed therapy in those patients we do have demonstrated mutations for. But in fact, currently there's no randomized controlled trial of using specific mutation-directed therapy versus a multi-targeted tyrosine kinase inhibitor up front, so it's not clear that that's any better. I'll show you a little bit of data behind redifferentiation therapy to try to facilitate radioactive iodine delivery. I thought I had to mention immunotherapy. Everybody knows that oncology is using tons of immune checkpoint inhibitors these days. I'm sure you're all thinking, why aren't you using one? So in fact, thyroid cancer has a pretty low tumor mutation burden. And to date, there's no clear role in, at least I should specify the differentiated thyroid cancers. There's no clear role for these immunotherapy drugs. And as we said, chemo is not that helpful. So what is the background to redifferentiation therapy? So we've already seen on the previous slides that the MAP kinase pathway is very often upregulated in these thyroid cancers, and that's important in driving the tumor growth. And when that MAP kinase pathway is upregulated, it also inhibits the sodium iodide symporter and thyroid peroxidase, which are important in iodine uptake and organification. So the kinases that inhibit signaling on that MAP kinase pathway potentially could allow re-expression of those genes that are responsible for iodine metabolism in radioactive iodine refractory differentiated thyroid cancer, and potentially could restore the RAI uptake. And that's sort of the idea of this redifferentiation therapy. So this a small study by Alan Ho and others published in the New England Journal in 2013, I think was one of the first sort of nice studies looking at redifferentiation therapy. So it's just a small number of patients whose tumours didn't have sufficient RAI uptake anymore to deliver a therapeutic dose. And so they initially proved that with an I-124 PET CT study, and it was done in a proper fashion with the low iodine diet, with the TSH stimulation prior to the scan, and so they knew that there wasn't sufficient RAI uptake. The patients were then given this Selumetinib, which is a MEK inhibitor, so it inhibits MEK1 and MEK2, so it's an inhibitor along that MAP kinase pathway. They were given that drug for about a month, and then they repeated the I-124 scan with the same rigorous conditions. They saw that in 12 of the 20 patients, in fact, after the month of the Selumetinib, there was actually significantly increased uptake in the second I-124 scan. And in 8 of them, it reached their pre-specified dosimetric threshold so that they felt that they would be able to deliver another therapeutic dose of radioactive iodine. So in the study, patients that didn't have an obvious improvement in their RAI uptake or iodine uptake, they just stopped the Selumetinib. In the patients that did have a positive response, to the point where it was worthwhile giving another dose of radioactive iodine, they continued the Selumetinib until they were able to have the RAI, and it was stopped a couple of days later. And then they had follow-up. They certainly had scans at 2 and 6 months afterwards, along with thyroid function, thyroglobulin measurements, and so on. So on the right here, we have the table of just these 8 patients who did have the significant increase in iodine uptake. And you can, and we can see in these bars, it's just showing us the % shrinkage in the cancer metastases. which I think really should be due to the radioactive iodine, because don't forget they're now off the selumetinib, and the TKIs tend to wear off pretty fast when you stop them. So all of those 8 patients who were able to have another dose of radioactive iodine did have either stable disease or a confirmed partial response with at least 30% reduction in size of their metastases, which was maintained for at least 6 months after the treatment. Obviously, this was pretty exciting data, and so the same group of Alan Ho and others tried to use the same drug, thinking, you know, how about if we actually move this forward in the treatment paradigm, can we improve results? And so they published this phase 3 randomized controlled trial, the so-called Astra Trial, in the Journal of Clinical Oncology in 2022, looking at that same MEK inhibitor, selumetinib, but with adjuvant radioactive iodine now in high-risk differentiated thyroid cancer. So this is really earlier in the disease. These patients don't have metastases. They're not RAI resistant. They're just high-risk, nasty, aggressive thyroid cancers, which are at high risk of failure. And so with their initial post-op RAI, they're looking at giving them the selumetinib versus not. So sadly in this trial, it didn't actually show a benefit. So what you can see here is the CR rate in both arms so the complete remission rate at 18 months. And so in fact, if they had selumetinib with the adjuvant radioactive iodine, only 40% of them were in remission at 18 months and 38% in the placebo arm. So no obvious benefit to moving this treatment forward. They obviously did pick a good high-risk group because it was a pretty poor complete remission rate, but no obvious benefits. And this forest plot is, again, just looking at different subgroups of patient in terms of various mutations, age, sex, and so on. And I think you can appreciate that the hazard ratios are sort of all just falling just side of the unity line with large confidence intervals, and there's no suggestion that there's any particular subgroup that benefits from this approach. So just finally going to quickly mention, just show you a very similar redifferentiation study. This is data out of the MD Anderson Cancer Institute. A bit of a sort of fairly similar approach, but this time they've looked at they've sort of done a little bit more mutation-directed therapy. So they had patients that had BRAF mutations that they used a BRAF and MEK inhibitor for, and patients with NRAS or KRAS mutations that had MEK inhibitors. Some of the patients, so the columns here on the left of that black line, it just shows you how long they had been on their targeted therapy before they had the radioactive iodine. So some of the patients had been on targeted drugs for a while before their oncologist thought, I'm going to try another radioiodine scan and see if there's more iodine uptake. And so in the patients who did have increased radioactive iodine uptake, they again had a dose of radioactive iodine. Again, the inhibitors were then stopped within days, and you can see here these bars out to the right of the black line are showing how many months the patients have been followed up post that dose of radioactive iodine, with the median being 14 months. Here we've got the patients after the radioactive iodine. The blue bars are really showing you the growth while they're on the tyrosine kinase inhibitor. So you can see there wasn't a lot of shift. One of the patients, the tumor had obviously grown. And in the orange shows the shrinkage of the tumours after the dose of radioactive iodine. So a few of them where there's not much happening, but certainly a few of those patients that did seem to get benefit from that subsequent dose of radioactive iodine. So just to summarise, differentiated thyroid cancer generally carries a favourable prognosis, and it's actually fairly uncommon for patients to die of their disease. A minority of these patients develop distant metastatic disease. Patients with radioactive iodine sensitive metastatic thyroid cancer also have good long-term survival, with more than 90% survival at 10 years if they're able to achieve a normal radioiodine scan post-treatment. Radioactive iodine refractory metastatic thyroid cancer has poor survival. This is where you get to meet the medical oncologist, and that's a 10% 10-year survival. Multi-targeted tyrosine kinase inhibitors significantly improve cancer control in radioactive iodine-resistant thyroid cancer, but they do carry a significant toxicity profile. I think we still have some work to do on this front. And I think, you know, there's obviously ongoing clinical trials. There are some redifferentiation trials ongoing in Australia also. So emerging role for tailored therapy and redifferentiation therapy. Thank you.
Thanks, Nicole. That was a very comprehensive exposition of thyroid cancer. Very good. Are there any questions? I've always got some questions. But does anybody else have any questions? Tim.
Thank you, Nicole. That was great. Just going back to the case, given that he's had 600 millicuries of I-131 to date, were he to progress on the multi-targeted TKI, what options would be available?
Yeah. So for the audience, the question is, with the patient's case, he's already had 600 millicuries of radioactive iodine. So when he progresses on the cabozantinib, what would the options be? And this is a great question. I'm kind of interested in the endocrinologist opinion as well. So he would actually qualify for a redifferentiation study, and I plan to put him forward for that. He's got a good performance status. I had a look because my concerns also are, you know, the more radioactive iodine we give, we obviously do increase the chance slightly of secondary leukemia and cancer, pulmonary fibrosis, dry mouth, salivary gland problems and things. So I was kind of thinking, are we stuck? Because we've already given 600 millicuries, but I've had a look and those patients are included in their clinical trials. So my first choice would be a redifferentiation trial. He has an NRAS mutation, and so they are actively recruiting. But I also have concerns about the toxicity of just continually delivering the RAI. I'm not sure if you have comments.
I'll defer to Sumati, but I'd be interested in her comments. But that would be exactly I mean, you can give all 600 millicuries with.
So traditionally, they have uptake in their metastatic lesions. More than 600 has been given, but you need to balance the risk. I think that would be the way we'd be heading, given that he has an NRAS mutation, to get him into a trial if he does progress on cabozantinib.
Yeah, so basically the discussion from the endocrinologist is that it is possible to give more than 600 millicuries of radioactive iodine. Obviously, we have to be very careful balancing, dose and side effect profile. But given his NRAS mutation, I think the general feeling is we should try to put him forward for a redifferentiated trial. And I forgot to note, but actually that first Selumetinib trial, all 5 of the patients with NRAS mutations all had increased uptake and were able to be submitted for further RAI. So it may be that the NRAS mutations in particular are quite sensitive to this approach.
So if I could just ask, for cytotoxic chemotherapy, you give multiple agents. Would you consider giving multiple agents in this situation?
So I think from the old days, they have used various different agents. I think most anthracyclines were most used and platinums and things. I don't think that there's no clear benefit to using combination chemotherapy because it is a fairly.
I mean the newer agents.
Oh, do you mean multiple of the tyrosine kinase inhibitors? Right. Sorry.
Yeah.
So that's a good question, and I think that's the sort of thing that's just in the area of research at the moment. And I agree that it seems like a good idea, doesn't it, to sort of target more than one pathway, but then we're already having problems with side effects. So I think that's very much not outside a clinical trial.
But BRAF inhibitors are there and increase the thing.
Yeah, that's right. So we do with BRAF and so in fact in thyroid cancer, so Dr. Chu was pointing out that in BRAF mutation, for example, in melanoma, we tend to use a BRAF inhibitor, for example, dabrafenib, along with a MEK inhibitor at the same time, which is helpful in melanoma. There's certainly been one small trial in thyroid cancer which shows you don't get an added benefit from adding in the MEK inhibitor, so you can just use the BRAF inhibitor. But it's maybe because these are fairly indolent cancers with less mutational burden, perhaps.
Yeah.
So just with not with well-differentiated thyroid cancers, but with anaplastic thyroid cancer, now the pathway, if they're not amenable to surgical intervention, to go for BRAF MEK inhibitor as first line. So if they're not amenable for surgery, BRAF MEK inhibitor as first line, and then to consider surgical intervention.
Yeah, thank you. So Dr. Prampal is pointing out in the anaplastic thyroid cancers, which we weren't discussing today, but which are a very aggressive form of thyroid cancer, really the upfront approach for them is to test early for a molecular, you know, an actionable mutation. So a significant number of them have BRAF mutations, and then really the treatment algorithm for those cancers now would be to try and use a BRAF and MEK inhibitor early in the disease course rather than going straight to surgery, because they are unfortunately aggressive and metastasize very early.
I've got a left field question, and that is, I've just been watching the mini series on Chernobyl. Are we seeing a lot more thyroid cancers as a result? And I imagine the answer is very much yes. And do you want to comment on that?
I'm pretty sure they did see increased thyroid cancer after Chernobyl. And Professor Greenaway is nodding, and I'm looking at my radiation oncology colleagues and thinking they know a lot about Chernobyl, I'm sure of it. So I think, yes, there was increased thyroid cancer after Chernobyl. Yep.
Just a comment, actually, I happen to know that one of the ways that Chernobyl was actually, or the public health implications were basically because of the action of Moscow at the time to give iodine capsules to the families, the children of significant individuals in the society, which was picked up. So there was a whole lot of interesting things, perhaps a little left field, but
Oh gosh.
Yeah.
So you were saying that the eminent families in Moscow,
Yes,
the children
yes.
were given iodine capsules, and this was to try
Yeah.
and protect them. Oh gosh, right.
And that was because they didn't have enough iodine capsules to go around, in fact. Yeah. Yep. Well, I think it's been a fascinating discussion today, and I'd like you to join with me in thanking Nicole and Jessie for